Assalamu alaikum. As promised earlier in one of my videos, that I will share a nephroureterectomy, which will include the dealing with the distal ureter and the specimen in case of upper tract TCC. So here is a video which is showing dealing with the hilum only. We have mobilized the colon and everything, and we have divided this gonadal vein to find the renal artery. You can see the small pulsations of the renal vein. There was a small vein which has been coagulated with the vessel sealer. Here below the vessel sealer, you can see the surface of aorta, and there is a lot of inflammatory tissue around the hilum of the kidney. So slowly and gradually we will try to deal with the hilum, and once we have done the hilum, we'll place the kidney in the pelvis, and then we will do the distal ureter part, the intramural part, transureterally dissecting around the ureteric orifice with the bladder cuff, and then we will open the case with the small Gibson's incision and deal with the rest of the ureter, showing the video as well. So this is most probably the lumbar vein. So dealing with all these lymphatic tissues is important. This is a 62 years old lady who has a coronary artery disease and was on anticoagulant clopidogrel. Clopidogrel were stopped 10 days ago, and then we proceeded with her procedure. So this lumbar vein is cut between the clips. She has a renal pelvis tumor, which is shown on the CT urography. Plus, we did a ureteroscopy as well to confirm the mass before proceeding with laparoscopic radical nephroureterectomy. You can see the adrenal vein as well, and the artery is located superior to the vein. And in the meanwhile, there was a small vein draining into the renal vein, which got avulsed from it, and there was a small hole. We tried to seal it with the sealer, but instead of sealing it, it became a little more large in size, and then we decided to stitch it with Proline 50. However, one of the colleagues advised to apply a Liga clip, and hence we applied a Liga clip, which remained there for a while, but then it dislodged. However, since the hole was small, it got sealed by itself. So we were lucky that a patient who was on anticoagulant, her platelets functioned well, her coagulation factors functioned well to seal that small hole in the vein. But during the process of dissection, now you can see that that clip has dislodged, and we have removed it from the field. However, that hole is sealed. So we quickly move on to the renal vein to apply just one clip, make a window sufficient enough behind the artery so that a clip can be applied, and then we can deal with the vein before that hole opens up again. So the window is sufficient enough. However, we are using this right angle to dissect the tissue behind the artery so that the hemalock clip does not catch the tissue behind the artery and is secure. So here you can see that the hole is starting to open up again. Now the vein is empty, and you can see that there is no circulation of blood through the vein, and we had already dissected the vein, so we started quickly clipping it before that crying wound in the vein starts crying again. So we applied 3 clips here, all of them secure enough. However, another matter emerged as we clipped the vein and cut it. We will discuss that as well. So this is once we clipped the artery, then we clipped the ureter as well to prevent any spillage of the malignant cells. As you can see that when we cut the vein, it started bleeding because there was a small another tributary coming to that portion. So we clipped that tributary separately. So the bleeding stopped a little. However, we still were not sure, so we applied another clip as well proximally on that small tributary here. Dissect that tributary, make a window, and then apply a clip to secure the place. It's a difficult situation, however. Yes, we are able to clip it successfully. And now complete the disconnecting of the vein. Mind you, there might be a small renal artery that we clipped. However, since we cut the vein in half and it started bleeding, so we were cautious that there might be some tributary draining into that portion. Once we are done with the vein, now we can safely deal with the artery and make window. In the meanwhile, our vessel sealer got out of order, so we had to use our bipolar forceps and the scissors, monopolar scissors, and suction to complete the rest of the dissection of the hilum as well as the kidney. Here we can see that the artery is branching. Slowly and gradually we are coagulating everything, and once we are done with the coagulation, we'll use our monopolar scissor to complete the dissection of the artery and then clip it. And then cut the artery and complete the rest of the dissection. Using monopolar diathermy or bipolar diathermy requires continuous suction. That suction is better applied by one of the assistants because it produces smoke, number one, the bipolar and the unipolar or monopolar, and it also produces a lot of oil So all that needs to be sucked out of the abdominal cavity in order to see things clearly. Now we use the right angle to complete the dissection of the artery from the posterior aspect in order to be able to place some more hemlock clips. We can see the jaws of the right angle, so we are now sure that we can apply clips safely and immediately. Once we apply these clips and disconnect the artery, the small lymphatics bleeding in the posterior area will be coagulated with rather ease. You can see the atheroma within the artery. So the rest of the dissection was completed using bipolar and monopolar. So now we go to the transurethral resection portion of the ureteric orifice with the bladder cup. Here you can see that we are using a hot knife or a Colon's knife, and we are drawing a circle. I will make the wound deep enough into the perivesical fat in the area from 1 o'clock to 11 o'clock, but the area from 11 o'clock to 1 o'clock will be left as such. The reason for that is, number one, we do not want to completely detach the ureter from the intramural portion, this area. It is only deep enough to cut the muscle fibers, but not deep into the perivesical fat. And number two, when doing the open part from the left iliac fossa using the Gibson's incision, this portion which we have left from 11 to 1 o'clock position, this will act to retract the bladder towards us, and that has a peculiar advantage that we can apply a stitch to close this wound. Although the bladder is catheterized for a good 10 days in order for this small hole to get healed. However, if a stitch is applied, the post-operative hematuria is significantly reduced. So we will take that advantage. Here you can see that the perivesical fat is there, also coagulating the edges of the mucosa and the muscle, which may bleed later. And we do not want any clot formation in the bladder in the post-operative period, because that would lead to extravasation of urine and things may get dirty. So you saw that we mobilized the intramural portion from all around, but we just left the area from 11 to 1 o'clock position, cutting only the mucosa. Now here we are opening the abdomen, the peritoneal cavity. We are keeping the gas inside because it is going to help us identify the peritoneum, and opening of the peritoneum is quite easy and without any risks if there is gas inside. Once we open the peritoneum, then we will remove all the cannulas and the gas. So here we are doing the subcutaneous tissue. This is the muscle in the external oblique. It's a 62 years old lady with a thin abdomen. Here you can see that we are on the peritoneum now. Of course, there is a little bit of bleeding from the muscles, and that needs to be addressed before opening the peritoneum. Once we open the peritoneum, everything will just retract. So then it will be difficult to control that bleed. The thin shiny layer of peritoneum can be seen. So we are now about to open the peritoneum after completing the dissection. We have removed the gas tube as we are about to open it. So now the peritoneum is open, all the gas is out. So we are lifting the abdominal wall in order to keep the intra-abdominal viscera, especially the sigmoid and the small bowel, safe. The wound is large enough to accommodate our hand, so we protect the wound by removing the specimen in the abdominal sponge. You can see the sigmoid now. So the specimen is out of the field. We will apply retraction, and we will deal with the distal ureter as well as the intramural portion. The uterus can be seen, fallopian tube can be seen. Good traction is required here, or good retraction is required here. So all these structures along the ureter need to be dissected off the ureter. This is the portion of that gonadal vein running along the ureter. So we ligate those. In order to denude the ureter. The portion remaining in the body needs to be transfixed. Okay. As promised before, we are now showing the dissection of the ureter, dealing with the intramural portion of the ureter. Slowly and gradually, we will dissect the peritoneum away from the ureter till we reach the lower end of the ureter, which is entering into the bladder. And now, it is worth mentioning here that the portion of the ureter that we kept remaining attached to the bladder will play its role, and you will see that how the stitch is applied. So we apply one stitch, and then we pull the stitch, and then we pull the rest of the ureter. And then we apply a figure of 8 or maybe 2 other stitches in order to close that hole in the bladder. Slowly and gradually, we are dissecting the ureter. Reaching towards its insertion into the bladder. As we all know, there are many vessels coming from here and there towards the lower ureter to supply it. So we may encounter a little bit of bleeding in the field, but we will try to control that as we go along the length of the ureter. So the main aim of this video was, number one, dealing with the hilum, maybe the use of bipolar and monopolar, and now dealing with the lower ureter. Okay, we are just on the bladder now. We are just on the bladder. And now you can see that. Now you can see that very clearly that the ureter is only attached. This is the intramural portion. It is only attached at that area of the bladder which was left. That was the area of the bladder, especially the muscle from 11 to 1 o'clock position. And we will use that as a leverage and apply stitch to close that wound. And post-operatively, this patient will have a clear catheter without the risk of getting clot retentions and making things difficult for us. Yes, you can see this is the portion of the muscle which is attached, and that is the hole in the bladder. So after pulling it, we apply a deep stitch into the muscle of the bladder, and then we pull this stitch, and then we clip the distal end of the ureter and just pull it, or maybe cut that attached portion with the diathermy, and then we can apply 1 or 2 stitches more to close that wound. So the drain will be placed in the pelvis, and the patient will remain catheterized for a week or 10 days. Thank you very much for watching.